In terms of disclosures, I have no conflicts of interest regarding this talk, and I am an employee of the US federal government, and the opinions in this presentation represents my own view and not those of the Department of Veterans Affairs or the United States government. So in terms of outline today, what I'm going to talk to you about is what led us to study long COVID. And then what is long COVID? And then now most commonly, referred to as post-acute sequela of SARS-CoV-2 infection. Talk a little bit about sort of what we think about sort of the differences between a post-viral syndrome in general, post-flu syndrome in general, and then post-COVID manifestations. What are sort of the similarities and differences between these two? And then, sort of broadly discuss what are the implications of long COVID. What we think about are the implications for health systems and also communities in general. So really, our interest in long COVID started, early in the pandemic when we, started, hearing reports from patients and patient-led groups that it isn't really just a mild virus that sort of precipitates an infection in the first 2 or 3 weeks, and then it completely resolves. And really, perhaps the most, and then the first eye-opening episode to this was an op-ed piece by Fiona Lowenstein in New York Times. Pretty sure you may have all heard about this. It was a remarkable, very early in the pandemic, that was actually in April 2020, recounting her story with quote unquote recovering from COVID, and it was really not the sort of the usual recovery for a otherwise healthy individual at that point, and that sort of generated a lot of interest from patients and patient-led groups, and then subsequently sort of ballooned or really blossomed to be a patient-led movement. And at the same time, we were clinical epidemiologists. We generally study chronic diseases. We don't really study, acute disease. We don't study viruses. We're not virologists or infectious disease epidemiologists. Start putting our heads together. It's like, how can we contribute to understanding this, and how can we do our part in the fight of against the pandemic, or in the sort of the collective effort to really generate new knowledge to help us fight this pandemic and optimize our public health response to it. And it became evident really, to myself and my group that we ought to do what we do best, is really marshal our resources and our science to address questions of relevance to the wider community. And long COVID was really one of them. And at that point, we didn't even know it had a name. We didn't even know it's called long COVID. And as I said, this sort of the early report, the early op-ed piece by Fiona sort of really blossomed into, a much bigger movement, a patient-led movement, really following the publication of her op-ed piece. A lot of patients reached out to her, and then they coalesced around each other and formed what we call now, the patient-led research collaborative in long COVID. And they published also early on that in May 2020, a survey, just a very simple survey of their membership, of their group, really telling, providing us with like early estimates, a glimpse that really weeks after the initial infection with COVID, a lot of them were having persistent symptoms in terms of persistent fatigue, shortness of breath, cough, and really myriad other manifestations. It wasn't really also limited only to respiratory symptoms. And that was actually really even more eye-opening. Like, okay, this is not an anecdotal 1 or 2 or 3. These are hundreds of people that are reporting, persistence of symptoms weeks after the initial infection. And they, to their credit, these early reports sort of they organized, these patient groups organized, and they, they coined the term long COVID, and they called themselves long haulers. So all of a sudden, all these, manifestations of the post-viral, post-COVID manifestations sort of had a name in the lay vernacular that people referred to as long COVID. And then people started referring to themselves as long haulers. So really, this is a, in the history of medicine, this will go down as a sort of an amazing, piece of development that actually was really ground-based, by patient-led. Like we really, like scientists did not coin the term long COVID. That was not the NIH, that was not the CDC, that was not us, it was not and it was really patients themselves that actually, termed the disease initially and described their manifestations. This is a really amazing piece of history, we think. So what is long COVID? So that's sort of all of this was to sort of form the genesis for us to really start thinking and pondering, like, how do we, characterize long COVID, or how do we really understand it? And really, we realized also early on that there was really not a whole lot of things known to even anchor a hypothesis. Generally you need a set of facts to even build your hypothesis on and ask the next question. In long COVID, there wasn't really much. So we really decided to take what we call like a hypothesis-free approach, a high-dimensional characterization of long COVID that is sort of a, really sort of to form the basis of how we really should approach long COVID. And we didn't want to do a biased approach looking at a specific organ, at the liver or the heart or the lung or the brain. So we took a comprehensive, we call it an unbiased, and you could call it also a hypothesis-free approach to really characterize the post-acute sequela of COVID-19. And then, in that work, sort of we there are multiple findings, but I'll draw your attention to the main ones here. So what we saw, comparatively speaking, when we compared people with COVID, 30-day survivors of COVID. So those are not acute sequela anymore. These are people who, did the first 30 days and survived the first 30 days, and we measured their, or we evaluated their sequela post 30 day of survival, compared to a weighted comparator group. So, but basically, sort of control for baseline health status. And what we found that long COVID is characterized by increased risk of mental illness or mental health problems, including anxiety, depression, sleep problems, substance abuse, nervous system disorders, actually quite a bit of strokes, headache, memory problems, smell problems, metabolic and endocrine manifestations, including obesity, new onset diabetes, which I myself didn't believe when we started this, like, oh, this is really cannot be a true signal of a virus, producing down the road increased risk of diabetes, high cholesterol, gastrointestinal manifestations, constipation, diarrhea, acid reflux disease, skin disorder, hair loss, rash, coagulation disorders. That's actually also weeks after the infection. We all know that in acute COVID, people get, deep vein thrombosis, and also pulmonary embolism. But really weeks down the road, also people present with new onset deep vein thrombosis and pulmonary embolism. Cardiovascular disorders, including acute coronary disease, heart disease, heart failure, palpitations, arrhythmias, respiratory problems, cough, shortness of breath, low blood oxygen, kidney problems, acute kidney injury and chronic kidney disease, really a lot of musculoskeletal manifestations, including joint pain, muscle weakness, and general problems like malaise, fatigue, and anemia. So really, we came to the conclusion that if you really evaluate sort of the post-acute manifestations in COVID versus the comparative group, long COVID, what we call now like long COVID or post-acute sequela of COVID-19, of SARS-CoV-2, can affect nearly every organ system, including mental health, nervous system, metabolic, gastrointestinal, skin disorders, coagulation, cardiovascular problems, respiratory problems, kidney problems, musculoskeletal problems, and general problems. And then, we wanted to, do a bit of an evaluation of COVID versus flu to try to, gain a better understanding. Are these manifestations that are happening post-COVID different what would happen, if somebody got, a seasonal influenza or a seasonal flu? And then, the short answer is like they're quite actually different in that the magnitude of risk when we evaluated patients who are hospitalized for COVID versus those people who were hospitalized for seasonal influenza, the risk of post-acute sequela is much, much higher with COVID than seasonal influenza. And the breadth of organ manifestations, the extent of organ injury, kidney, heart, lung, and liver, and other and brain and other organs is much, much more pronounced in post-COVID than post-influenza. So yes, in post-influenza, people report fatigue weeks after the initial infection. People have lingering respiratory symptoms weeks after the initial infection. So a post-viral syndrome or post-viral, sequela, that's nothing new. It's sort of like not really a novel thing. It's been known that some people get the flu and don't really fully recover, weeks after the initial infection, have lingering, symptoms X, Y, Z. But comparatively speaking, COVID is actually much, much worse in terms of the magnitude of risk itself and the breadth of organ manifestation. So our conclusion here is that it's really a different kind of post-viral syndrome. It isn't really a post-viral flu. It's not like the post-flu. It's much, much more pronounced. So it's certainly different animal, so to speak. And then we wanted to understand if all the risk is really concentrated in people whose acute disease was really severe at baseline that necessitated hospitalization or perhaps even admission to the intensive care unit. So what we found is that the risk was evident even in those people whose disease was not severe enough to necessitate hospitalization. Those non-hospitalized people with COVID represent the majority of people with COVID in the United States and actually globally. Most people, when they get COVID, they do not get hospitalized for it. They don't get admitted to the ICU for it. Most people with COVID nurse it at home and they quote unquote recover in 2, 3, 4 weeks. So the risk is evident among non-hospitalized. However, it was actually much more pronounced in people who were hospitalized and highest in people who needed ICU care during the acute phase of the infection. There are several sequelae of concern that I think we should really talk about here as well. So we see a higher risk in post-COVID, a higher risk of mental health disorders, including anxiety, depression, sleep disturbances, PTSD. And that, I think, we sort of what really warrants a better understanding now and addressing it proactively, so so it doesn't balloon into a larger mental health crisis down the road. Just given the huge number of people potentially impacted by long COVID in the US, even if a small percentage of them have mental health problems, I think addressing these issues now will really hopefully prevent it from ballooning into a serious crisis down the road. We do see, and it's also disconcerting, that some of the, some patients are complaining of pain, and we do see increased risk of opioid use or opioid medication use in people with long COVID. And again, here we definitely realize that pain is a real thing and it must be treated. But we sort of think that exploring other options first and keeping opioid as a last resort should be the main message here. And again, this really requires sort of attention and focus from physicians and researchers and public health officials, so it doesn't balloon to another opioid crisis down the road. There is really a substantial risk of cardiovascular disorders. A lot of people say, like, oh, is long COVID something that will go away with time, that maybe like linger for 2, 3, 4, 5, 6 months and then improves? And the truth is there are some sequelae or some clinical manifestations of long COVID that might get better with time or might resolve completely with time. But it's also evident, it's very clear to us that some sequelae of long COVID or some manifestations of long COVID are chronic conditions that will last a lifetime. Those include cardiovascular disorders like heart failure, acute coronary disease, and other cardiovascular disorders. So that we think is a burden that sort of will in some individuals will actually be or morph into chronic conditions and will require nearly lifelong care. There is nervous system and neurocognitive disorders, and also, as I alluded to, metabolic disorders, including new onset diabetes. Story there is that when we first started seeing signals in diabetes in our data and our patients, I almost didn't believe it. I almost think oh, this is really must be an error in the data. Went back to the drawing board, redid the analyses once, twice, 3 times, and the signal was consistently there. Now, since that time, there's been other corroborating reports from everywhere, Italy, a lot in the US, and a lot of other countries, also saying the same thing. So we feel that this sort of the metabolic signature in long COVID is really there and has been corroborated actually by a lot of other evidence from other data sources and other studies. So you might ask, like, why would SARS-CoV-2 or would like a respiratory virus really be may result in sequelae in other organ systems? And it really doesn't. This doesn't really prove it. But receptors for SARS-CoV-2, and I'm maybe preaching to the choir here. You guys are all virologists and immunologists. I'm just a clinical epidemiologist. SARS-CoV-2 receptors receptors are present in a wide variety of human cells, including a lot of the organs that we think are targeted or are they manifest in sequela in PASC or PASC or long COVID, including kidneys, obviously lung, heart, brain, et cetera, et cetera. So, and this does not prove that, but it sort of, suggests that, maybe there's sort of a viral interaction with those organs. Our thinking about it is a bit sort of broader. So this is sort of a slide where we that illustrates sort of what we think is sort of going on in long COVID, the mechanisms of long COVID, and it's really a conceptual framework at this point. So we think it's plausible, it's likely, it's potentially could be happening that that there is a direct pathway that involves the virus itself or the immune response of the host. It is also possible that our indirect pathway, in the sense that the infection with COVID-19 in the context of the pandemic, with all the characteristics sort of like really characterizes the pandemic, including loss of employment for some people, reduced social contact and isolation, changes in dietary habit, changes in physical activity, other stressors, grief, trauma, environmental factors, and other contextual characteristics. All of them may coalesce to be differentially more expressed in people who got exposed to COVID and had acute COVID, and the result in the phenotype that now we call long COVID. It's also possible, a third pathway, that there are unrealized pre-existing conditions that as a result of the infection of the acute COVID infection itself and interaction with the healthcare system, that is increased healthcare utilization, those previously unrealized conditions may now become realized. So all of these pathways may coalesce together to produce either new onset disease, a disease that the person did not have before and now manifests as new onset diabetes or new onset, heart disease or heart failure, et cetera, et cetera, et cetera. Or, the confluence of these pathways, and they're not mutually exclusive, may also amplify baseline risks and lead to progression of subclinical conditions. So people may have had, subclinical diabetes now as a result of the infection, and potentially some, changes in diet and exercise, and so those subclinical conditions or that subclinical diabetes may now manifest as overt and new onset diabetes that's clinically evident. And clearly, the third pathway is really unrealized conditions that have now been realized as a consequence of interaction with the healthcare system in the context of having an acute COVID-19 infection. That is sort of discovery of previously unrealized condition. So all these pathways may coalesce to produce the phenotype of long COVID. They're certainly not mutually exclusive. So we don't really think it's only like the virus and sort of virus interaction with the host that's sort of producing all these manifestations. We think sort of it's likely the constellation of all these pathways, working together to produce the phenotype. So in terms of the burden of long COVID, and that's really, I think, was a very, very important question that needs to be addressed, is that we think it's really substantial. This is another op-ed piece by Fiona Lowenstein and Hannah Davis in New York Times, suggesting that long COVID is not rare. They write, a year later, we struggle to be taken seriously. And we think that's really very important. Few think that long COVID can happen to them or that will even affect their post-pandemic life. But long COVID is not a footnote to the pandemic or a curious human interest story. It's America's next big health crisis, and we should prepare for it now. So we completely agree. And we also think that when we pay attention to acute COVID, we're really only seeing the tip of the iceberg, the toll of hospitalization, and now 600,000 deaths in the United States. That is the tip of the iceberg. You're seeing that those consequences of acute COVID that we count, the 600,000 deaths, is only the tip of the iceberg. Post-acute COVID is resulting in serious disease and disability, is resulting in early mortality, and we think that will have profound implications on life expectancy in the United States. We also think, because a lot of the huge number of people potentially affected will have wide economic implications. social implications, scarring families and friends, and et cetera, et cetera, et cetera. And then the IMF, the International Monetary Fund, projects also there might likely be consequences of global unrest. So this is not without consequences, both social, economic, political, and also security implication. This is not a sort of a disease that's affecting 100,000 people, 200,000 people. These are millions of people affected potentially in the United States, and much larger number of people affected in the world. So at this point, we need to realize that when we measure the toll of COVID, we are really talking about the tip of the iceberg. We think over the next several years, we'll start slowly, understanding what's beneath that tip, and then understanding sort of the long shadow of COVID. So what are the implications for health systems? So we think that the burden of long COVID is likely substantial. There's no official estimate yet. There are no really very rigorous studies that would provide us with a really good estimate. So ballpark, based on the WHO reports and several other publications, we think it's in the vicinity of 4 to 10% of people with COVID-19. And you might think, well, that's really a small percentage. It's not really huge. But multiply that by the 30 million people, or actually more than 32 million people now infected with COVID in the United States. That's potentially millions of people impacted with long COVID. Long COVID is a multifaceted disease that can affect nearly every organ system. We also think that it will be accompanied by rise in burden of non-communicable diseases, as cardiovascular disease, cerebrovascular disease, metabolic diseases like kidney disease and diabetes, and that COVID acts as an accelerant or amplifier of baseline risks, and then also might produce or might result in the emergence of new sequelae. We think it's imperative that governments and health systems prepare for the tide of patients in need of post-COVID care. And that actually has been happening so far. The National Health Service in the UK stood up post-COVID clinics throughout the country. They have more than 40 now operational. The VA healthcare system in the US is doing the same thing. There are several large health systems in the US that have up and running post-COVID clinics. I'm pretty sure in New York there's quite a bit. Many post-COVID conditions can be managed by primary care providers. So not everything needs to go to the post-COVID clinic. A lot of people may have headache and other sequelae that might be easily managed in the setting of a primary care clinic with the incorporation of patient-centered approaches. Some patients, however, will require multidisciplinary post-COVID care. The optimal composition of those clinics is not yet known. Now, we think people should leverage the principles of learning healthcare systems and iterate as we know more. We have to be humble about what we know or what we don't know. There's a lot of things on long COVID that we do not know. And I think we have to be pragmatic and flexible and adjust and iterate as we know more, as the science tells us more. So the optimal composition at this point is not clear. There's no hard scientific evidence that tells us that this is really the best model. It's currently under investigation, but we don't know the answers to those questions yet. And in our view, at this point, it should include providers who are able to address respiratory, cardiometabolic, mental, and neurologic sequelae. So implications for community: the best way to prevent COVID is to prevent long COVID is to prevent COVID through vaccination. I may be preaching to the choir here, but really vaccinate. That's really the best way to prevent the disease. We cannot ignore the elephant in the room. What's sort of a vaccine hesitancy and long COVID, misinformation around vaccines and misinformation around long COVID should not really be ignored. And in our view, should actually be actively opposed. And both communities and the medical community should be actively doing more to really provide counter narrative to really hopefully reduce to the extent possible or mitigate that misinformation. It's really ill effects on society. It's not without bad consequences. This is really sort of consequential thing, and it really should be actively opposed. And I started the talk by sort of thinking a lot of what inspired us is really the patient-led groups and how they framed their long COVID story, their long COVID narrative, and how that sort of really inspired us to really do the work that we do. And then last but not least, really medical gaslighting. I think sort of some in the medical professions, like long COVID is all in your head, it's psychosomatic. I think we sort of should really shy away from this and deal with facts. In summary, long COVID is a multifaceted disease. It can affect nearly every organ system. the burden of long COVID is evident even among non-hospitalized. That's really the largest, the group of people with COVID. Burden of long COVID is increased with severity of the acute infection. We think governments and health systems must adapt quickly and establish post-COVID care strategies. That's really, really very important. I really want to acknowledge, the members of my team who really contributed to this, including Yan Shea and Benjamin Bowe, and Miao Kai, Andrew Gibson, Evan Zhu, and really acknowledge our funders, U.S. Department of Veterans Affairs, Veterinary Research and Education Foundation, and the American Society of Nephrology. And really, most importantly, the long haulers who really inspire us to do this work. We wouldn't be doing this had it not been for them. They've been a source of inspiration for us from day one. They really enlightened us and sort of helped help us form our, or develop our research question, and inspired us to move forward with this. And then with that, I'll take your questions.
All right. Thank you so much for that really, really important talk, interesting talk. I agree, this is going to be a huge problem that is probably still underappreciated in many settings. So I think it's really important to get the word out about this. So I had one question. In the beginning, you mentioned how this was really a patient-reported disease, more than a physician-reported disease. And that reminded me so much of chronic fatigue syndrome. And then as you went through the symptoms, I started thinking this is chronic fatigue syndrome. And I wondered to what extent you think that is true. That is, how much is this an example of chronic fatigue, which, may be triggered by many viruses?
So yeah, that is a really very important question. So there are a lot of similarities, and admittedly, actually, we don't really know a whole lot about chronic fatigue syndrome. So like the general that has been underfunded for so long, and not a whole lot of people really delving deeper into it. So we don't really fully understand it. They share a lot of similarities. At this point, I think we still don't know the mechanisms, the biologic mechanisms driving long COVID or responsible for some of those manifestations. Clinically, there are a lot of shared similarities, and also there's certainly a lot of shared similarities. But honestly, our understanding stops there at this point. I think we have a lot to do as a community of researchers. But it is totally true also that the patient-led movement in long COVID has also galvanized again and breathed new life into the chronic fatigue syndrome community, and they're also galvanized and hopefully hopefully more attention now on long COVID will also generate a lot of researchers, will stimulate a lot of researchers to study MECFS and hopefully provide us with answers.
Just one more sort of related question, which is in the previous pandemics, in flu in 1918, is there anything similar to this, or was it just never known? Or
this is absolutely wonderful. We wondered the same thing, but I think at that point there wasn't really sort of a lot of well-developed clinical epidemiology science, so EHR, electronic health records, and all this data and all this computer infrastructure to be able to do what we do today. So it wasn't really. We looked, we tried to see if that so there are reports here and there of people not fully recovering, but there isn't really any formal report or formal publications or research that has been published that we could rely on. It's like, oh, this is what was described in the early in the flu pandemic. So we don't know. It may have happened at that point, but we really don't know.
Okay, so we have a couple of questions in the box. So one from William Honer says, has analysis considered whether the sequelae could be precipitated, at least in part, by specific treatments such as steroids, especially in hospitalized patients? So I guess you look for correlations with steroid treatment.
Yes, so this is a very important question, and the answer is no. It's unlikely to be related to steroids. We see the same signal in people who are non-hospitalized, and we see the same signal in people who are exposed to steroids, and a whole bunch of people who are not treated with steroids. So not everybody got steroids when they got hospitalized or went to the ICU, and there's really no difference on so steroids themselves, they can actually disturb glucose homeostasis, increase blood sugar, et cetera, et cetera, et cetera. That's definitely known, but however, the post-acute sequela, especially the metabolic signatures, are actually present in people who are not exposed to steroid. Actually, most importantly, actually present and very clearly evident in people who are not hospitalized or actually totally not treated. There were actually now reports that in people who had acute infection that was almost asymptomatic, very, very mild symptom to asymptomatic, but a weeks later they start having, new sequela.
Yeah, so certainly you don't need steroid treatment to get the syndrome. Right.
But it's important to know that steroids themselves also increase blood sugar. So steroids, I mean, they definitely have also side effects, and then some of those side effects sort of overlap with some of the manifestations seen here. I think this is what the person who asked the question is alluding to. Absolutely correct. You're right on that. Like steroids themselves can also produce some of the increased blood sugar, et cetera, and manifestation might overlap with long COVID.
All right, and we had one more from David Cohen, who asked, there have been some reports on long COVID improving, resolving following vaccination. So the question, I guess, is, does vaccination help? Might it help?
This is a very, very important question. So anecdotally, yes, and there is a small study, less than 100 people, that said that, okay, well, after administration of vaccine, some patients reported amelioration as some symptoms. So I don't think we can say definitively that this is really ameliorated symptoms in everybody. So there are anecdotal observations here and there. And a very small study suggesting that following the administration of vaccine, people report some amelioration of some symptoms. However, I have to say that long COVID is a lot of things and include a variety of manifestations. Some of them are clearly actually might improve with time and actually might respond to vaccine administration, but some of them are actually clearly things that are chronic conditions that will likely not respond to vaccines. But I think the jury is still out. It's really anecdotal observation and one small study.
Yeah, I suppose the issue there is whether residual virus is involved, or whether and the vaccine might help that. So yes. Here's a related question from Darcy Kelly, who says, are there any data available as to whether the Regeneron antibodies, for example, or other monoclonal antibodies would prevent long COVID?
Yeah, we don't have the data yet. I mean, again, like the number of people who really actually got the antibodies is actually relatively small in the United States, not really huge numbers. And we don't have the follow-up studies on the percentage of them that actually went on to develop long COVID or not. So those are undergoing, but we don't have the answer to this yet. It's plausible, but we don't know the answer to this yet.
Okay, and then there's one from an anonymous attendee who just asks, are the manifestations treated as you would treat the symptoms otherwise? I mean, I guess, probably many of these are treated for the symptoms rather than anything beyond that. Yeah.
At this point, yes, and that's also consistent with the CDC guide that came out actually 2 days ago. So we're on the same page with the CDC. So a lot of those manifestations we recommend, to primary care physicians, post-COVID clinics to pursue, like the treatment strategies that we know work, and evidence accrues as we learn more about these conditions, especially in long COVID, and what they might respond to and not respond to. I think we have to be flexible and pragmatic and adjust our treatment strategies, our care pathways accordingly. But the CDC came up with guidelines actually just only 2 days ago on the 14th, and that's really a general recommendation that we would treat it like we would treat, so for example, like headache as a sequela of long COVID. It should be addressed as a headache in the primary care clinic, and until we know otherwise.